Hi, everybody. It gives me great pleasure to introduce our second conversation, an initiative of the International Society of Hypertension Communications Committee. I'm delighted to introduce our Secretary, ISH Secretary Professor George Stergiou here. Joined as well is Professor Atul Pathak, who was one of the Guidelines Taskforce members and past president of the French Hypertension Society. And of course, you all know Associate Professor, or Professor I should say now, Dylan Berger from our communications. Welcome, everybody.
Thank you.
Thank you.
It's a pleasure to be able to share this with you now. This is our second video, and so we've had some time. The guidelines have been released for a few months, and I'm wondering, maybe we'll start with Professor Pathak, what sort of feedback you've received on the guidelines to date?
Well, you know, it's quite strange. It's a mixed feeling. So a lot of waiting, a lot of excitation, new guidelines, and then once it was released, mixed feeling. For some, it was a kind of add-on with some changes, some new things. We'll go through that later on. For others, it was not a big deal. So I would say mixed feeling, but what I'm saying as being a co-author of these guidelines, hey guys, you have to read the 180 pages. And then we discuss. And I think that the difficult task we'll have today is maybe to wrap up some points, some key points. And I think I'm sure you're going to do a great job to try to extract what are really the highlights of these guidelines.
Thank you, Professor Pathak. Professor Stergiou, what are your thoughts? What sort of feedback have you heard?
Well, no question, the ISH guidelines are the event of the year, and there were a lot of expectations by people to see what is coming from the ISH. They are very influential guidelines in Europe and out of Europe. So the first thing, very long document, 150 pages. And this is something to admire because this is a valuable source of information. And of course, you need time to read deeply all the details. But of course, the document allows the reader who doesn't want to spend too much time to go just to the recommendation statements. So within the long statement, you have the, let's say, prescriptive information for those who do not want to spend more time. But as Professor Pathak said, we need to spend time to reflect on the changes and understand how we can transform a document into practice.
Thank you. Professor Pathak, the ESH guidelines coincide with the 20th anniversary, or the release, I should say, of the ESH guidelines, which were first authored in 2003. What would you say has been the impact of the ESH guidelines on improving the management of hypertension over these last two decades?
Well, I think that there are probably a couple of points which could summarize the trend induced by the release and the consecutive release of guidelines. First, raising awareness about this silent killer. And I think guidelines are always a red flag to alert the community. Hey guys, don't forget, we have here a silent disease which needs to be detected and treated. And I think all guidelines have repeatedly challenged the community to still try to think about hypertension whenever you see a patient. Second, I think the diagnostic part has also raised a lot of attention because we move from office measurement to home and ABPM, and maybe George will talk about cuffless. He's an expert in the field. We try to see the disease initially as just a hemodynamic disease where everything was about blood pressure. And we went to something with a more holistic approach where blood pressure was part of something which was the global cardiovascular risk. We started treating the patient with single pill monotherapy and move to combination therapy, treating earlier, faster, in a more aggressive way. And finally, these guidelines have also identified some group of patients who are treated, I think, better. I'm looking at you, Anastasia, maybe taking into account gender differences, children, obese patient, cancer patient, and the last point probably also trying to take into account newcomers, and not only drugs, but also devices. So I think these are probably the 5 major points which have reshaped the management of hypertension throughout all the release and led to, let's say, a better control of hypertension, though not perfect, but still, I would say, a valuable trend, which is probably supported by these guidelines.
Thank you. Professor Stergiou, it has been 3 years since our ISH guidelines were published and circulated. Could you share how they have impacted on improving the management of hypertension to date?
This is a very important question, but it's very difficult to answer because we don't have metrics to see whether the purpose of publishing guidelines has been fulfilled. So the metrics is the citations, which is not doesn't mean that we change practice, but it's something like 3,000 citations so far. But I think we should here discuss a little bit the purpose of the ISH guidelines. The ISH is a different organization. It is a global organization. And at that time, when the ISH guidelines were developed, the decision was not to replicate the American or the British or the UK guidelines, who provided extensive systematic reviews of the evidence, but to give a prescriptive manuscript for clinical practice. And I think this was something that ISH offered. Of course, the key question, which I didn't answer, is how to make sure that we have a real impact in practice. It's difficult to say, but I think such a concise document with characteristics of implementation, we hope that helped implementation of the knowledge we have for hypertension today.
Thank you.
Excellent. So Professor Pathak referred to this a little earlier, but one of the comments that has appeared in editorials a few times now is that the ESH guidelines focused on incremental rather than major changes. So Professor Pathak, do you agree with this statement? And if so, was that a deliberate choice or something that happened serendipitously?
Yeah, I mean, I don't want to go too far into the backstage of how do you build guidelines, because it's maybe not the appropriate place, but you have to understand it's a very difficult task. You have to review the literature, and George mentioned, if you look, it's not just about the number of pages, it's about also the references, the way you want to cite it, the way you want to integrate the information. And also there is an issue, which is the timeline. So you have to stop recruiting references at a certain time. That's why we are always missing the latest information and guidelines. You have to start from where you have left the community, so the previous guidelines, and you have to build up evidence according to this time frame. So within this time frame, I think that some changes have been made in these guidelines. For me, they are, let's say, the 10 commandments of these guidelines: importance of ABPM, caution about cuffless, try to enlarge the need for screen of secondary hypertension. I think we are missing too many cases of primary aldo or of renal artery stenosis. Try to treat earlier in a more aggressive way patients who are in secondary prevention with a lower cutoff. Try to bring these ischemic heart disease patients, for example, below 130/80. Also, that's, I think, a new finding: no impact of the time of where you are taking the drugs, referring to the HYGIA and the time trial, morning versus evening. Finally, in these patients who are complicated to manage, low eGFR, below 30 milliliters per minute, you can combine loop diuretic with Hyzide. In those above who are still resisting, you can use now renal denervation. Specific chapters: women, obesity, cancer, children, try to adapt and treat as early as possible pregnant women with hypertension, and finally, talking about newcomers, integration of SGLT2 inhibitors and finerenone in these guidelines. So these are, in a very quick way, I would say 10 bullet points, which are the real highlights of these guidelines, taking into account new evidence or the need to improve the quality of care for hypertensive patients.
And Professor Stergiou, do you have thoughts on to what extent the advances were incremental versus major changes?
Professor Pathak actually listed the main key points of the new guidelines, but I'll make some more general comments. The science of guidelines as it evolved in the last 3 decades or a little longer has 2 aspects. One is the accumulation of data, which is continuous, which means as much as you do in Canada, every day you should give us the today guidelines. And this is also a demand by the public to implement any new information rather than to wait another 5 years to publish new guidelines. So this is one, is the data. The second, which is more tricky, is the interpretation of the data, which takes longer time, and it has a subjective aspect. Now, talking about hypertension is different because it's one of the most well-studied areas in medicine. Whichever question you put, the answer is based on a list of studies with thousands of people and years of follow-up. So it's a special scenario for guidelines. And so we have advanced this field so far, and you can't expect so many changes, major changes, as we did in the past. For example, ABPM was mentioned. If you look at the document that the ESH published on ambulatory monitoring, it's a huge document by itself. So it is natural that from now and on, in such a well-studied disease and condition, we found what we have to do. And we are just refining and interpreting more appropriately the evidence. We always can do something better, but I think we have done most of the job.
Said.
Professor Pathak, as immediate past president of the French Hypertension Society, to what extent do the other guidelines like the Japanese, the Canadian, American Heart Association, and ISH influence the development of the ESH guidelines, do you think?
Yeah, I think a very good question. When we started working on these guidelines, we had the 3 pillars, our previous guidelines, the American Heart Association guidelines, AHA-ACC, and ISH. These were the 3 pillars. And Giuseppe Mancia and Reinhold Kreuz told us, well, you start building up something, but you start from these 3 pillars. So they have been, let's say, not included, but they have been used as the backbone of the guideline which have been released. Now, answering more precisely to your question, what has probably inspired us from these different guidelines? I think some concept in the American Heart Association or American guidelines, unattended blood pressure, maybe not mentioned, but discussed. How do you define resistance, for example, or be more strict in diagnosing and treating to target the patient? We were inspired by the ISH guidelines about the use of diuretics, taking into account some subpopulation around the world, taking it into account also something we don't always talk about, which is the climate, the food, the specificity of not subpopulation, which are tiny. I'm talking about millions of patients when you focus on Southeast Asia or Africa. And from our colleagues from Canada, probably the concept of how to update at the best information. And also, we have to say, a very large involvement of patient science. And I think Canada is really in the forefront about that, how to integrate data, which will increase awareness empower the patient, boost adherence, involve the patient in care. And this is what has been coming from Canada. So I really like this question, Anastasia, because you are right. Guidelines cannot stand by themselves. They need to be inspired by other guidelines. And these were some examples of inspiration we had when writing these guidelines.
Thank you. Professor Stergiou, to what extent do you think that the ESH guidelines influenced the development of other international guidelines, in particular our International Society of Hypertension guidelines?
Any group that develops guidelines should probably naturally look at what is there already. And this is the same for the ISH. The ISH looked very carefully at the ESH guidelines, as well as the American guidelines and the NICE guidelines. And also you have to realize here that this is not a debate, because I was co-author of the ESH guidelines, the data are the same, the people in part are the same. Of course, the interpretation can be different, and the purpose can be different. And here I'd like to say that when the ISH decided in 2020 to develop its own guidelines, first, we have 3 extensive documents, and there was no point to have another one. We don't do any service by publishing another 4th recent systematic research of the evidence. But we needed to come out with something which fulfilled another need. And this is what we did by providing the so-called optimal and essential needs depending on the resources of settings, not countries, settings, because even high-income countries have low resource settings and the opposite. So I think this is the unique service that the ISH offered at the time.
Thank you.
Professor Pathak, what do you think is the most contentious decision or recommendation in the ESH guidelines, or perhaps just the one that you expect the most pushback from the hypertension community on?
Well, I would say, and I'm biased because you know my passion and my interest in the field, but I think it's about real innovation, because you know, it's in the community of people who are taking care of hypertensive patients, it's a major change. Shifting from drug therapy to device means you have to reset the way you are managing the patient, in the way you talk with them, in the way you share the data with them, in the way you organize also how to offer the therapy, because we need to work with new type of doctors. We need to interact with interventional cardiologists. We need to talk about procedure to a patient, which was limited probably to treating hyperaldosteronism with surgery. This was the only intervention we were sharing with our patient, so few. And now suddenly, we have a device, we have a therapy which has been validated with a higher level of evidence. And in a large bulk of patients, I'm talking not only about the uncontrolled resistant hypertensive patient, but also those who are intolerant to drug, those who are starting their disease, and those more generally who would like, that's what we call patient preferences, be treated by a device rather than a drug. So I think it's a major challenge, a major advance, but also a difficult task to convince the community, because it's totally changing our vision and the way we have to talk and we have to manage the patient. Because if you are not an interventional cardiologist, or let's say a cardiologist, in the community, we are not used to talk about procedure and devices. And I think probably if I had to pick one, it would be this one.
Thank you. Professor Stergiou, you have a unique perspective, having been involved in the ESH guidelines, but also the ISH perspective. The guidelines were also endorsed by ISH. So I'm wondering what item or aspect you think is likely to be most discussed by our global membership.
Of course, the denervation is the most novel recommendation. But I'll also discuss the role of beta blockers, which are becoming controversial. And I have to say that sometimes we scientists like very much the scientific intellectual exercise to compare guidelines. So the indications for beta blockers, I think, will raise some discussion. Whereas, in my opinion, they shouldn't, because there is nothing new. The ESH just reminds us that there are more cases, more scenarios where beta blockers should be preferred rather than this hard indication, heart failure, post-MI, and so on. And I don't really think that it is such a major difference from previous guidelines. So for denervation, well, denervation is causing discussion for quite a long time. And it's important to realize that. It's probably more than 10 years that you are looking carefully at this, really revolutionary approach for hypertension therapy. We are looking how to make it more efficient, how to select the patients more appropriately. And I think the ESH have been careful in protecting the method of being misused and being directed to the right people, and quite quantifying the expected magnitude. Because, you know, when you have something new, you are all enthusiastic, you need some time to really understand where this can be useful. And they think we know where it can be useful. I'm sure we get it better, but I think it's time to start using this in selected cases.
Thank you. Professor Pathak, you nicely summarized the key elements in the ESH guidelines. And as you pointed out, there were specific populations identified. What some of the questions that have been coming through social media are that for the first time, the ESH guidelines included a pediatric section directly within the guidelines rather than a separate independent document. How did you come to this decision, and is this the plan going forward?
Yeah, I think it's a good point, Anastasia. I think to make the story short, the timeline was supporting the fact that rather to doing an independent document, just have it inside. But as George mentioned, there are a lot of chapters which are documents by themselves. I mean, if you look at the measurement, it could have been a standalone by itself. Okay. But for time reason, we thought, okay, we'll have a blurring effect. We will maybe miss out the information. We will pollute if we have two separate documents, or maybe the guidelines will totally hide the importance of information regarding children. So this was, I would say, the strategic decision. Second, this part of the guideline is really important because this is, I would say, not the new pandemic, referring to what we had with COVID, but the new epidemic. And I'm sure we all as physicians are really challenged by these grown-up teenagers getting more and more obese, coming here for various reasons. Like I was impressed, ADHD, treated with drugs which are increasing blood pressure. You see a lot of these children refer to us, do they have hypertension? Can you start the treatment? Obese, you see all these patients were referred by endocrinologists. Do we need to treat, how should we treat them? So this was really a matter of concern, okay? And because the amount of pediatric physicians is not as important as those who are dealing with hypertension, we also thought that opening this part will allow for better care, because at least children could be seen by cardiologists, by endocrinologists, by nephrologists for the management of their hypertension, and also by child specialists, but not only, in the same way you would do for adults, where you would include GP with other specialists. So there was a strategic decision, and then there was a medical, epidemiological decision to have this chapter included in the guidelines, because it's really, I think, a matter of concern for the coming years.
Thank you. I think there's a strong support for that as well from our community.
And if I may
yes.
add, Anastasia, sorry, I think because we're also talking ESH, ISH, I think this is also something which is now as important from a global perspective. You see these countries which are called whatever, low social, low economic countries, but I'm talking about maybe India, about Brazil. In these countries, the middle class children are getting obese. They are having hypertension. So probably in these countries, we might be overwhelmed by hypertension coming from the children more than from the adults. So this is really a matter of concern, which is really going beyond ESH. I think ESH has started something, but probably that ISH will be more concerned by this specific aspect about children and this epidemic of hypertension in children.
I congratulate the task force for addressing that issue because it's a major one. Professor Stergiou, what guidance does the ISH provide, ISH, I should say, apologies, provide for pediatric hypertension?
I'm glad that you asked this question because it's important, and we have a problem here. But let's first see what each society did. The ISH does not have recommendations, but only resources. And the resources are the American Guidelines for Pediatric Hypertension and the European Society of Hypertension guidelines specifically for pediatric hypertension. So the ISH has resources. What the ISH has today is only mentions pediatric hypertension. It's half a page. So pediatric hypertension is not easy. You can't go out and see children and adolescents because you read this part. We have the problem that pediatricians are unfamiliar with hypertension. They don't have so many cases. And adult doctors, internists, and cardiologists are unfamiliar with children. So this is a problem. And if you want to deal with children and adolescents with hypertension, you need to go for the full ESH or the full American paper. There are many aspects that need to be addressed, and doctors need to get experience. It's like pregnancy. You can't read a short article and go out and see pregnant women. So I think this ESH now just includes a warning that this is a special population. And we have the ESH guidelines for pediatric hypertension, which presents all the necessary information than what might have to deal with these cases. And also Americans did that as well, but not the ISH.
Thank you.
Professor Pathak, when you were highlighting the evolution of the guidelines over the last 20 years, one of the things that you did highlight was the progressive acknowledgement of sex and gender aspects of hypertension, which are now sort of at the forefront of the ESH guidelines. One of the things that is recognized is that using ABPM may uncover differences in cardiovascular risk at lower systolic blood pressure ranges for females. But home blood pressure monitoring and not ABPM is the recommended alternative to conventional office BP. So can you comment on that perhaps?
Yeah, it's really, I think I love this discussion because it's also giving to the audience insight about how you frame guidelines and what are the thoughts behind guidelines. So somehow in the same way you do with clinical trial, where you talk about external validity, how can I apply data from a clinical trial to my clinical practice, okay? Do the patient who have been included in the trial look like the patient I'm seeing in my clinical practice? This is one of the reasons, okay? Scientifically, and again, I'm talking under the control of Anastasia, scientifically, from a clinical point of view, from a nosological point of view, ABPM is the gold standard for many reasons, okay? For physiological reasons, pathophysiological reasons, according to the type of woman you are dealing, postmenopausal, menopausal, pregnant woman, young woman. But from a practical standpoint of view, we thought that home blood pressure is available everywhere in Europe. We are covering a large part of the continent. And we thought, okay, this is a good way to convince the community to start doing something more specifically and really challenge the physician to measure blood pressure out of the office. And the good start for that, because it's easy, it's not expensive, it's not complicated, everybody can buy a device. Let's start with HBPM. So this was the reason behind, more a concept of external validity. What can you offer to the community which is easy to apply everywhere?
Thank you for that. Professor Stergiou, could you remind us what the ISH advice is for the measurement of blood pressure in non-pregnant females?
Well, this is the other special population, and the ISH guidelines have a section about the crucial role of hypertension in the short term in pregnancy. And we have information about the devices which need special separate validation, about the important use of ABPM based on evidence, and about home monitoring. And I think it's important, this comment that Atul made, that sometimes we have to consider practicality versus evidence, because some people may not like that, but ABPM will never be a solution for most of our cases. We have much more evidence than for home. It has unique advantages, but it can't work for this huge population of people with hypertension, be it adults or even children or pregnancy. We know that home blood pressure is inferior, but it can give us a lot of information. And even if you have ABPM and you have a pregnant woman or a child, how many times are you going to use it? And how are you going to follow the treatment? So it is a compromise to accept a method with inferior evidence in favor of practicality for our patients.
So seeing that you both were on the task force, and Professor Stergiou also with the ISH guidelines, something that we asked in our first interview, and we'd like to get your expert opinion, because it's something we were discussing here as well, is to what extent do you think recommendations in guidelines balance between practicality and ideal practice, i.e. aspirational? Professor Stergiou, I'll go with you first this time. Excuse me, Atul.
First, the doctors need to do the job, which means we must give them prescriptive recommendations, how to do the job. But particularly the young doctors, the scientists, they hate it. They are scientists. They know, they want to know why they should do what they should do. They need to understand the mechanism of the disease and management. Otherwise, we can have medical assistants to do the job. So I think we need to do the job. We need to highlight the recommendations and statements as it is clearly framed in boxes within this long ESH document, but we also need to tell them why and how, not only how to do the job. So we certainly need both.
Thank you. Atul?
Well, I have to confess that ISH has done a great job, because they came up with a tool with colors, with figures, with tables, which are easy to understand, practical, and easy to apply. I think if I had to make one criticism to the own guidelines I've been co-authoring, it's the document by itself is great, but we are missing maybe a document which is connecting the guidelines with clinical practice. And I think the example you made and what you came up with was great. So the information is there, but how to use the information is something we could make more lively. So there are tables, there are figures, but I think really there is a job, and there is something there where we can improve the way to make these guidelines available and practical. Because, and this is the way you also work, you extract the information, and if you have time, you go back and you try to dig into the details or the references. This is probably where we might improve the things, but nothing is over. The document has been drafted. The society is working on that, the communication aspect. You've maybe noticed that there are no official slides, and we are working on the pedagogic material to support this translation from guidelines to clinical practice. I think this is key. If you want them to be applied, you need to make them available and understandable.
Thank you.
Thank you. Professor Pathak, perhaps extending from that discussion on practicality, there are clear differences in size, resources, and healthcare delivery amongst the countries in Europe. How does that impact the development of the ESH guidelines, if it does?
It's almost philosophy or politics, okay? Do you want to be the Vatican and define a law and everybody has to follow the law, okay? Or do you want to be, let's say, a political party where everybody is equal and everybody has the right to share his opinion and discuss, okay? And that's the difficulty with guidelines. What is right and what should be done, okay? The theory, the practice, the evidence, the care. And you have to find a way to combine this. But I think George mentioned it clearly. I mean, the rules of guidelines are to define the level of evidence, okay? What have we learned? What do we know? What should be done? And that's why we grade also the level of evidence, 1A, 2B, etc. And I think in this field, there was a major change in the guidelines. I don't know if you have noticed that, but we moved from the classical evaluation 1A, 2B, 3C to something slightly different, which is helping doctors to link evidence to clinical practice. The other problem, as I mentioned, is that you need to do guidelines for a community of doctors. We are talking about ESH. So how do you define the European community? Is a doctor working in France doing the same job as somebody who is in Slovenia? Is a patient who is eating fish maybe in Portugal having the same diet as somebody who's in the north of Europe? And you have to have the same type of material, the same type of information. So this is probably why you have sometimes a mismatch, not 100%, but a slight mismatch between evidence and what we state in guidelines, because at the end, we want the guidelines to be applied. If you say you need to do this and it's impossible to apply, well, what is where's the need to come up with guidelines? So we tried to incorporate authors from different parts of Europe, readers and people who've been to the manuscript from different parts of authors, taking into account this discrepancy in the same way you have done at ISH, where you have defined the patient from sub-Saharan Africa, but also from Southeast Asia, which are not eating the same thing, but which are concerned by salt, for example, and try to make it available and practical for our audience. But this was probably the most difficult task. Try to make practical and available everywhere something which is based on evidence, and you could distort evidence or not try evidence. This is the tricky and complex part.
Thank you very much. Professor Stergiou, the ISH guidelines employed an essential and then an optimal recommendations for controlled blood pressure. Was this intentional to accommodate such differences in regional resources? And if so, do you think it's been effective?
I think this was a very important decision, and because we as doctors, we are supposed to do the optimal for our patients, the optimal, no compromises. But this does not fit with the reality. I know which is the best car on the market, but I can't buy it. So otherwise I won't have any meal for dinner. So I think we have to recommend, we have to say what is optimal, what is available or based on the best evidence we have today. But in the end of the day, we have to explain to the doctors what is the essential. If we don't do that, when the doctor is not able to invest for the optimal, he can't decide what is essential. And the essential will probably give you 70 or 80% of the benefit. And it's not about poor and rich countries. all countries have low resource settings, and all countries have all high income areas. So I think it is a very important to give the minimal to the practitioner and tell them you can't go lower than that.
Thank you very much.
I think it's a concept that we should have in mind and help practitioners when they can't do the optimal, which is common, how to select what they should prefer and put the right priorities, which they cannot do without guidance.
Thank you. I'll ask this question of both of you because it's something we all think our viewers will want to know. Atul, what is the take-home message from this conversation and the guidelines, in your opinion?
I would say there is still space for improvement in the management of hypertension, and that this disease is not an old horse, but it's a horse which is running fast, which needs to be controlled, which needs to be known. And I think that these guidelines are adding up knowledge in order to improve the quality of care for our patient. And I think also, summarizing the conversation we had, the story never ends. You will have your guidelines and we'll probably have another meeting together, I hope. And then we'll have the ESC guidelines and we'll have another meeting. So that's also the interesting part. My take-home message is that these guidelines are up to date. They are taking into account the latest level of evidence. They are as practical as possible, though bulky, needs to be understood and read, and should, if followed, help us to better care about our hypertensive patients.
Thank you. Professor Stergiou.
As a last comment, I think we have to realize and accept where we are with hypertension in 2023. And we are at a very good point in terms of evidence. We have most of the answers. We did the work. We know what we should be doing. We have very strong evidence. Very few areas in medicine have this advantage. And we have broad agreement on the diagnosis and management plan. There is, as I said before, it is intellectual exercise to compare guidelines because we have a consensus. What is missing? The implementation. And I've been following the Canadian guidelines for quite a long time. And I always remember that these guys have a group of crazy scientists who do the...
Just be careful, you've got a Canadian on this.
No, I have a good one. They write the paper, but they have another committee, which is Guidelines Implementation Committee. So publishing one more paper doesn't change anything. And this goes to your the previous question, what is the impact? Not the impact factor, but the impact in practice. So controlling the general population. This does not go align with the research we have. So what we need to do, we need other initiatives. We have done the healthcare professionals. We need to change how we approach them, but we have to find initiatives to change how healthcare systems see hypertension, how patients and public see hypertension. So we have not a knowledge issue now, we've done that. We have an implementation issue, and this is where we should be focusing from now on.
Thank you very much. And on that note, I think we're all in agreement that this discussion helps towards that cause in starting people talking. I think once you get the community to start engaging in the issue, then you're more likely to get some change. So on that note, thank you very much, Professor Atul Pathak, Professor George Stergiou, Professor Dylan Berger, and I forgot to introduce myself, Anastasia, for this conversation. We really enjoyed it, and thank you.